Okay, I think we'll make a start. Good afternoon, everyone, or good morning, or good evening, whichever is relevant to you and where you are in the world. Welcome to the ISBNPA webinar. My name's Dr. Gareth Jones. I'm from Sheffield Hallam University in England, and I'm hosting today alongside two colleagues, Eleanor and Olivia. If you want to quickly introduce yourselves.
Hi, I'm Eleanor, based at Imperial in the UK. Nice to meet you, everyone.
Hi everyone, my name's Olivia Finnegan. I'm a doctoral candidate at the University of South Carolina in the US, and I'm on the executive committee for the Children and Families SIG.
Thank you both. So I'm just going to provide a very brief introduction to this webinar and some housekeeping as well. So as part of ISBNPA, they organise these webinars as an extra service to their members. These webinars are all organised by the special interest groups of ISBNPA, and you can see a full list of the special interest groups and how to join them on the website. So as you will know already, we're using Zoom today, and in the system, all delegates are kind of muted, except for those who are speaking and the organisers. This just helps prevent and keeps us kind of concentrated, helps keep noise down and so on, and helps us kind of concentrate on the talks. However, we would really like to promote that everyone kind of contributes, perhaps through the Q&A. So if you do have any questions or anything, please do use that element to the Zoom call today. Interact with us, and all questions will kind of be answered towards the end. The organisers, Eleanor and Olivia, will aggregate the comments at the end of the talk and ask questions on behalf of the audience. So feel free to ask questions along the way as you kind of go through, and we'll aggregate those towards the end of the talk. But just remember that we will ask them on behalf of yourselves as the presenters. Each presenter will talk for about 10 to 12 minutes, and then we'll have about 15 minutes for questions at the end. This webinar is a joint webinar from the Children and Families, the Young Adults, and the Mental Health and Wellbeing Special Interest Groups. And the session will address how lifestyle factors such as physical activity and diet can play a crucial role in mental well-being across different age groups. And we're delighted to have three fantastic speakers for you today: Professor Andy Smith from Edge Hill University, UK, Associate Professor Felipe Barreto Schuch from Federal University of Santa Maria, Brazil, and Lu Yang, PhD candidate from University Medical Center Groningen in the Netherlands. So without further ado, we'll introduce the first speakers. I'm just going to stop sharing for a second, and then Andy can just kind of start to prepare. So our first speaker is Professor Andy Smith from Edge Hill University, UK. Andy is Professor in Sport, Education and Mental Health, and a Director for the Centre of Mental Health, Sport and Physical Activity at Edge Hill University. Andy's research focusing on the links between sport, education and mental health in local communities and educational sectors and in professional sport settings. The title of Andy's talk today is Children and Young People's Mental Health and Physical Activity and Evidence Review. Take it away, Andy.
Thanks, Gareth, and welcome to everyone who's able to join us today. Thanks very much for attending wherever you are in the world. I'm delighted to be asked to speak very briefly today around an independent evidence review that myself and colleagues here at Edge Hill were commissioned to do on behalf of Sport England. And the focus of the review, which we conducted between research on 1st of January 2004 to 3rd of April 2024. The review focused on three key areas: sport and physical activity interventions for children and young people who, for the purposes of this review, are defined as aged 5 to 25 with a diagnosed mental health condition. It also included those who are waiting for or on a mental health treatment pathway as diagnosed by a GP or another mental health specialist. The mental health conditions and their symptoms, which we included in the review, included depression, anxiety, eating disorders, self-harm, bipolar disorder, and schizophrenia. A modified grade approach was used to assess the quality of the body of evidence, which we defined as strong, moderate, or weak. And what I will go through today is the strength of that evidence and what that means both for our current understanding of the use of physical activity and sport interventions for children and young people with diagnosed mental health conditions, but also the policy and practice implications of that more generally. The research we undertook involved 143 studies, which were included in the final analysis. We derived those from a wider sample of just over 12,500 records from relevant databases, which we searched. A total of just over 7,000, over 7,500 articles were screened based on the types of sport or physical activity interventions that were reported in the research, as well as mental health condition and so on. A variety of study designs were represented in the research, as were the types of settings in which interventions were delivered and the target mental health conditions for each of those interventions. There were a diverse range of study designs, the most popular and common of which were randomized control trials, of which there were 29%. 12% of the articles which were included in the final analysis reported on systematic reviews or meta-analyses. 12% were pre-post studies and 10% were qualitative evaluations of the interventions reported. 28% of the study settings were either in hospital or healthcare settings, with a further 19% delivered in education. The two most common conditions which were the focus of the interventions reported in the research were depression and anxiety, which reflects the tendency for those two conditions to be reported by children and young people, but also adults worldwide. We assessed the strength of the evidence based on 5 key factors. This included the amount of evidence that was available, the consistency of the findings, the relatedness of the evidence, the rigor of the study designs, which is something we will come back to shortly, together with the timeliness of the research within the 20-year period that we conducted the research. Based on the meta-analysis evidence and the RCT evidence, overall the findings concluded that sport and physical activity do have positive effects on the diagnosed mental health problems of children and young people. In relation to the types of exercise, the meta-analysis evidence indicated that aerobic exercise was the most common intervention that was reported in the research, and those types of interventions had a moderate effect on depression in the population under review. By contrast, the evidence was defined as strong if the interventions included an aerobic component plus resistance exercise. Although those interventions were less commonly reported in the research, they did have strong effects on symptoms of depression in children and young people. In terms of intensity of activity, moderate to high intensity activity, which was most effective in treating depression and anxiety. The most optimum intervention dose, which was reported in the evidence which was deemed to be strong, ranged from between 4 bouts of 30 minutes per week to 3 bouts of between 20 and 60 minutes per week, between 6 to 12 weeks on average. Significantly, in relation to the types of delivery in which those interventions occurred, the exercise in group environments had a stronger effect on mental health when compared to one-to-one or individual exercise. There are a number of caveats that we need to take into account in relation to the meta-analysis evidence that was reported in the research. Firstly, the methodological quality of the studies in those analyses were typically low. and heterogeneity usually high. The mental health outcomes, which were reported inconsistently at times and with varying levels of rigor. And there was also limited information in some of the studies on intervention delivery, content, and dose. And those three challenges also need to be borne in mind alongside an additional challenge, which was the tendency for most analyses to not report or recognise sufficiently the importance of participants' habitual physical activity levels prior to the intervention. These are clearly among some, but not all, of the areas that future research in this developing area needs to consider and focus on moving forward. But despite some of the limitations of the quality of evidence which is currently available in this area, there are some conclusions which we can draw for both the providers of activity opportunities and for those who wish to deliver physical activity opportunities to benefit the mental health of children and young people. On the basis of the evidence, that we have so far, it's clearly important that we promote diverse forms of aerobic and resistance exercise of at least moderate intensity, and particularly in group settings where the interventions are led by appropriately qualified staff. Those group-based interventions should clearly be tailored to individual needs, and there is clearly another significant opportunity to integrate physical activity into mental health services and to promote long-term engagement in physical activity for mental health benefits among those diagnosed with mental health problems among the children and young people population. The focus of those interventions should also begin to recognise the significance of the inequalities which exist, both in physical activity participation among children and young people, but also experiences of mental health problems which are diagnosed by GPs or for those who are on mental health treatment pathways. But of course, all of those intervention messaging should be responsible and focus on developing healthy relationships between physical activity as well as the focus on mental health and well-being more generally. We were also asked as part of the review to identify relevant messages for policymakers, funders and commissioners of physical activity interventions, which are important for children and young people. We identified 5 broad messages. The first of which was to recognise the positive impact that cross-sector sport and physical activity investment can have in supporting the wider mental health promotion efforts for those who wish to work with children and young people in a range of settings, including those which were reported on in the review. Also important, but not also widely reported in some of the research, is the importance of learning from the lived experience of mental health problems among children and young people and how those can be used to help design interventions and to help assess the evaluation activities and priorities of those. Prioritising the collaborative and integrated approaches is also important if we're to better leverage systems change in which physical activity can be used as a method of supporting those with diagnosed mental health problems. And the embedded nature of those interventions into relevant services is important, particularly given that much of the research that currently exists has either been conducted in kind of hospital or other healthcare settings or education. There are other systems in which activity can be delivered more broadly, and we need to certainly consider those more generally moving forward. And finally, to reinforce the point raised earlier, we also need to address the complex determinants and inequalities that exist prior to intervention development, and how we begin to address those as part of, but not solely as part of the responsibility of those types of interventions. There's clearly far more detail than we've been able to capture in 10 minutes today, both in the report, which you can see on the screen in front of you, which is freely available on the Sport England website, together with a slide deck and recording of the wider report launch, together with a series of infographic assets, some of which I've shown you here today, and that's accessible through the Mental Health and Sport England pages, which I've hyperlinked here, but which are accessible via Google by simply searching Sport England and mental health. But I think we're just around on time, so I would thank you very much again for listening, and I'll be happy to take questions later on.
Thanks, Andy. That was a fascinating talk, and definitely got my mind racing, and I've got one or two questions in my head, so I might, if I've got time, I'll kind of pop them in as well at the end. So we're now going to go on to our second speaker of today, which is Associate Professor Felipe Barreto Schuch from Federal University of Santa Maria, Brazil. Felipe gained his doctorate in 2015 in medical sciences psychiatry, now an associate professor at Federal University of Santa Maria, as I said, and coordinator of the physical activity and mental health research group. Felipe is a kind of a rising star in the field and being listed as one of the most cited authors in the area of psychology and psychiatry in 2020, 2021 and 2022. The title of Felipe's talk today is Assessing the Association Between Lifestyle and Mental Health Symptoms in an International Cohort, Partial Results of the Unilife M Study. Take it away, Felipe.
Hello, everyone. Thank you very much for being here. It's just a pleasure for me to be able to talk about this initiative. So I'm gonna try to go quick to present the study and the partial results we have so far. So briefly, the rationale of the study is that university students, when they enter at the university, are passing through a major life changes, like they have to face new challenges, they have to face new responsibilities, and eventually move from different places and engage in different social roles. And usually this transition can be associated with many changes on lifestyle behaviors, like where they have to adapt to a new role, to a new place and a new position. And these adaptations may result in lower physical activity levels, poorest diet tactics, habits, and many other many other changes in lifestyle behaviors. And it also coincides the moment that they enter at the university with the age where most mental health disorders emerge. So the age of onset for most mental disorders happens between 17 and 25 and 30 years. So this is once again the period when most university students engage at the university. So we have a plethora of evidence showing that many lifestyle behaviors like physical activity, sedentary behavior, diet and nutrition, and smoking, and many others are associated with increased risk of developing a mental health disorder, or even with a heightened risk of having mental health symptoms like depressive symptoms and anxiety symptoms. But we have seen from some initial evidence that not all lifestyle behaviors will have the same impact on mental health outcomes across different cultures and countries. So we have some evidence showing that physical activity, for example, may have different impact on mental health outcomes in different places, in different cultures and countries. And also we have some evidence like where drinking alcohol, moderate consumption of alcohol may be associated with better mental health outcomes among German students and worse mental health outcomes among Chinese students. So we have some evidence showing that lifestyle behaviors may have not the same impact on different mental health outcomes across different populations of students. Also, we have some most of the evidence we have so far evaluating mental health outcomes, evaluating the association between lifestyle behaviors and mental health outcomes come from studies evaluating a single lifestyle behavior or a single mental health outcomes. And we know so far that lifestyle behaviors, they are not completely independent from each other, but they happen associated with each other. For example, people with higher physical activity levels, they are also the ones that are more likely to have better dietetic habits. And eventually, in some cultures, they are also the same, that will have higher alcohol and substance consumption, for example. And when we look to a single independent lifestyle behavior and its association with mental health outcomes, we may have missing part of this story. So the idea and the aim of this study is to evaluate the associations between lifestyle behaviors, multiple lifestyle behaviors, and multiple mental health outcomes in an international cohort of university students. So we have over 80 universities participating in the study in 25 countries. We have universities in all continents so far. And inclusion criteria is students including entering at the university at the first semester, so freshman students aged to 16 to 35 years. And all the recruitment process happened sending emails to the students, but also sharing the link with in social medias, and also going to face-to-face invitations on presential letters with the students. So any method of recruitment with the student for the students are valid. So the study design is that we have a baseline assessment that happened in 2023 and 2024 academic years. So we are ending now the baseline assessments for some universities in Europe and some parts of Asia. And then we have 1 year, 2 year, and 1.5 years follow-up. So we have 3 follow-ups to assess prospectively. To assess mental health behaviors, we are using the USmile, a scale developed by Flavio Kapczynski and Vincent Balanza. And the scale assesses many different lifestyle behaviors, including diet and nutrition, physical activity and substance use, stress management, sleep, social support, and environment and screen time exposure. To assess mental health symptoms, we are using a 2 levels approach where all students answer to the level 1 questionnaire that includes lots of symptoms, and those screening positive in these symptoms at the level 1 questionnaire will then have answer a second questionnaire related to that specific symptom. For example, if a student screens positive for depression, and then the student will answer the PHQ-9 questionnaire. And we have some different questionnaires for different mental health symptoms. For depression and anxiety that I'm going to be presenting the partial results today, we are using the PHQ-9 as the second level questionnaire and the GAD-7 for anxiety as the second level questionnaire. These are not the final results. So by April 24, we had 15,000 students participating, mostly from South America and Germany. This scenario changed a little bit. We have now nearly 23,000 students from all these continents. This is the country where most of students come from, so mostly Brazilians and Germans, but we have many other participations from many other countries. So this is the baseline characteristics of the sample. Mean age 20 years, is a bit high so far. Mostly women, most single. Nearly 20% of the students reported having a previous mental health disorder. 9% are taking medication, psychiatric or psychotropic medication. Nearly 12% are under psychotherapy. for a mental health problem. This is the results of the U-SMILE questionnaire. So we have scoring different, but most students reported having healthy habits, healthy lifestyle behavior regarding substance use, so likely expected. So the poorest scores come from stress management in some different countries, and followed by poor sleep in most students in most places. The prevalence of depressive symptoms vary substantially between different countries. And the highest prevalence, which is consistent with literature, is among Brazilian students, when they have over the half of the sample reporting had the depressive symptoms. And
3 minutes left.
Similar. Okay. And we have also a high prevalence of anxiety symptoms among our cohort, but the highest prevalence is among the Brazilian students. So when we look at the associations, we have seen that lifestyle behaviors independently associate with with mental health outcomes. But when we have a composite score of all mental health outcomes, of all lifestyle behaviors, we can see that the students that have better lifestyle behaviors in all domains have also the lowest prevalence of depression, and the same for anxiety. The most important and the most strongly associated mental health lifestyle behaviors with depression and anxiety is sleep, for the same for these symptoms. So we have seen that also better lifestyle or healthier lifestyle is associated with a lower risk of having the co-occurrence of mental health symptoms, and as healthier is lifestyle behaviors in a composite score, as lower is the risk of having mental health symptoms. This is true for the overall analysis, and also for diet and nutrition, and for also for physical activity. So this is the main teams, the studies, the UniLife leaders and main collaborators. And this is the UFSM local team. This is the team that is behind the most of the organization of the study. So thank you very much for your attention. Maybe I just gone through quite quickly, but I hope it was useful. Thank you very much for your attention.
Thank you, Felipe, for another really interesting talk there. And then we come to our last presenter of this webinar today, Lu Yang, last but not least, from the University Medical Center Groningen in the Netherlands. Lu Yang holds a Bachelor of Medicine and a Master's of Public Health from Nanjing Medical University, focusing on gene-environment interactions and the impact on the reproductive health and non-communicable diseases. She has experience in clinical and pharmaceutical settings and is now pursuing a PhD in human movement sciences, researching how early life physical activity promotes mental health. The title of Lu's talk today is Associations Between Early Life Physical Activity and Mental Health in School-Aged Children, the Get-Go Strength Cohort. Take it away, Lu.
Thank you. Yeah, okay. Hello, everyone. Thank you for having me. Yeah. Can you see my screen? The full screen?
Yeah, we can see it all. Yeah, it's perfect.
Yeah, okay, good. Okay, I'm very happy to join this meeting today. I'm Lu Yang, and today I'm going to share a part of my PhD project that's a prospective analysis of Heckle-Durant's cohort study. Actually, it's also a work has been published on the International Journal of Behavior, Nutrition, and Physical Activity last year. Let's start with the background. As we all know, the mental health is a global public health concern, and mental health problems affect almost like 10 to 20% of children and adolescents worldwide. Almost half of mental disorders in adults diagnosed and adults actually emerged before 14 years old. So this reminds us to pay attention to the mental problems in young people. Meanwhile, physical activity play a important role in the prevention and management of those mental health problems. Its effects may from several potential mechanisms. For example, like doing physical activity can change the structure and function of the brain. And another thing is that physical activity can improve the mental health by satisfying those very basic psychosocial needs. For example, meet our needs to social connection, self-acceptance, even the life purpose. Another thing is that doing physical activity can change our behavior. For example, doing exercise can change our sleep quality and sleep pattern by increasing the energy expenditure. As a result, those mental problems caused by lack of sleep may improve. So based on this kind of background, our study aims to explore how physical activity in early childhood may affect the mental health in later childhood. This is important because early life is a very special period for the rapid developmental changes, and understanding the relationship between these periods actually can help us to develop early intervention to promote mental health. Let's move on to the methods. This study is designed based on Heck-Durant's cohort study. This first cohort follow up those parents and children from the Northern Netherlands, and this study focusing on the early life risk. In 2006, nearly 3,000 pregnant women were enrolled in this study. They and their kids were followed till now. When those children were aged 5, physical activity were measured by accelerometer and mental health were measured by a questionnaire. At age 10 to 11, the mental health in these children were measured again. After selection, finally, there are 850 children were enrolled in our analysis for this study. Let's see. It's still for the physical activity. It was measured by active graph, and we used those cutoff points applicable to children to define the time spent in sedentary behavior and different level of physical activity. For mental health, we used the SDQ questionnaire. This questionnaire is a valid screening tool and can be completed by parents in this study. This questionnaire is a very simple example. It includes 5 sub-skills. They are peer problems, hyperactivity, emotional problems, behavior problems, and prosocial behavior. For the first 4 sub-skills, higher scores means higher risk. For the last one, prosocial behavior, lower score means higher risk. So now let's move on to results. Here is a figure about the SDQ at age 10 to 11. We can see that boys have a higher scores in hyperactivity and peer problems than girls. As for the physical activity, we can see at age 5, boys spend less sedentary time than girls, and they spend significantly more time in MVPA than girls. These results basically tell us to notice the sex difference when we're trying to interpret those data results. So when we're checking the association between the physical activity and mental health, we do the analysis in boys and girls separately. Then we find some meaningful results with the peer problems and hyperactivity. Let's go with the peer problems. Firstly, in this table, we can see that we used three models. The first one is the Crew model. The second model is our primary model. This model adjusts for age, BMI, family size, maternal education, season, and accelerometer wearing time. According to the data, we can see that the higher level of physical activity, especially the MVPA associated with less peer problems at age 10 in boys and girls. In contrast, more time spent in sedentary behavior at age 5 associated with higher risk of peer problems at age 10. We considering that the baseline mental health conditions may be a factor that influence the relationship. We additionally adjust for the peer problems at age 5 to control this, and the adjustment results show that associations and significance were not changed. Then we also find some significant results about hyperactivity. Different from the peer problem, we find that actually more higher levels of physical activity at age 5 associated with higher scores of hyperactivity at age 5. In contrast, more sedentary time at age 5 associated with less hyperactivity at age 10 to 11, but all those findings are only in boys. After adjustment, this association was attenuated, but the direction of the association was not changed. So according to these studies, we have some key summaries. The first one is children who are more active. That means those children who have more MVPA and less sedentary time in early life, they may have fewer peer problems in middle childhood. Interesting is that we find that as for the peer problem part, the girls can benefit from the MVPA in a similar way of boys.
2 minutes left.
Yeah, okay. For boys, greater activity levels early in life actually can be an indicator of hyperactivity in later childhood. As a follow-up, what we are doing is to explore if the association between the physical activity and mental health vary across different type of activity. In another, we have published work. We find that the children in teamwork actually showed better cognitive function in middle childhood than those people only engaged in individual sports. That means the type of physical activity doesn't matter, but we also want to check if it still matters in those long-term and short-term effects on the mental health in children. Then we also curious about how the physical activity interact with the internal factor. I mean the genetic factors, and how this kind of interaction affect the mental health in children. So that's our future work. That's all the information I want to give today. And if you have any questions, I'm very happy to answer.
Thank you very much, Lou. That was another great presentation. Again, I've got a few sort of questions whirling around in my head, so if I get time at the end, I might ask one of those as well. So I'm now going to hand over to Eleanor and Olivia, who will kind of field through some of the questions that you guys have been kind of going through and posting up as the presentations have happened. Please, if you do have any other kind of questions or follow-up questions, then do just pop them in the chat or the Q&A function. And between Eleanor and Olivia, they will get to them. So over to you guys.
Great. Thank you, Gareth. So I think me and Olivia are going to take turns going through your questions. So like Gareth said, do get them up there. We'll start at the beginning. So if you get your question in sooner, there's more chance that you'll have time to have it answered. So yeah, I think we'll be going back to Andy's talk to start with, because some of the earlier questions that came up probably are primarily for Andy. But I think as we go through, if other people from the different talks have things to contribute on each of the questions, do feel free to jump in, because it's nice if it's a bit more of a discussion rather than just simply Q&A. So I think we start with a question from Nanette Strobel-Benshop. Did you see any difference in terms of types of physical activity and its effectiveness in different mental illnesses? Andy.
Thanks, Eleanor. Yeah, and great question. Thanks very much for that. It was certainly something that we intended to set out to explore, but actually the evidence was rather light in that respect. Actually, there were lots of different types of activities, but not a sufficient number or breadth of research that enabled us to do a type by type analysis. Although we do explain that in more detail in the report, so the primary focus of much of the established research as it's published currently focuses on the types of activity in very broad terms, so aerobic, resistance, anaerobic, for example, rather than more individual types of activities, for example, football, running, and so on. Some of the interventions that were reported did include a focus on interventions including yoga, tai chi, as well as things like mindfulness, so in association with exercise more generally. But there wasn't a consistent or clear pattern around the types of activities that were reported. So that was one of the things that we suggested that the research base certainly needs to begin to address moving forward, particularly if you're to compare team sports, for example, with more individual forms of activity and exercise, and within each of those are the particular types of activities which yield greater benefits for different types of conditions.
Great, thanks, Andy.
Awesome. So next we have a question from Jonathan Kumaris. Apologies if I don't pronounce your name correctly. Considering the dual continuum of mental health and illness, how can physical activity interventions be promoted both to individuals who have or have not received a mental illness diagnosis as a way to enhance mental health and decrease mental illness onset and severity, and or as a treatment modality? Is it the same, or are there unique approaches with those diagnosed mental illness?
Did you want me to pick that up first, Olivia?
Yes, apologies. So that was for you, Professor
No,
Andy Smith.
great, thanks. Again, another great question to which, there's no easy answer. I think that some of those types of approaches do share some similar design principles and methods that we need to consider, both in terms of how the interventions are promoted and participants are recruited. One of the key challenges or differences with working with children and young people with diagnosed conditions is the types of conditions that they experience, whether they're dual or comorbidities, and of course, as I think was flagged in the question below as well, one of the big barriers to activity, for example, will be the presence of low mood or other forms of experience. So being able to address some of those specific unique challenges is important when we're dealing with interventions which focus on diagnosed mental health conditions. And there is a recognition in some of the literature that is something that we need to consider, and how we recruit and how we support people to engage in interventions. Responsible messaging, I also flagged in the presentation, is something which is particularly important, whether we're promoting mental health of everybody or whether we're addressing mental illness or mental health problems in populations, particularly those who may find exercise a challenge or over-exercising a challenge, together with eating disorders, for example, is one particular condition, which is well reported in the literature that for which that is particularly relevant. So there are some unique challenges for interventions that do focus on people with diagnosed mental health problems, but there are some kind of common intervention design principles that are relevant to both, and we probably need a dual focus on both of those, particularly given the related nature of those types of conditions.
Great. And Felipe, Lou, is there anything that you wanted to add, either on the question about the dual continuum of mental health and physical activity, or interventions in particular?
Yeah, well, I think about prescribing exercise and physical activity to mental health people with a mental health diagnosis is quite challenging, as the proper mental health symptoms add some barriers regarding low mood and low energy and fatigue. And obviously, this makes prescription and recommendation to exercise a bit different. Actually, prescribing and recommending and making someone more active is quite challenging for everybody that are not doing physical activity, and it's even more because someone with a mental health disorder. But the main thing is that we should try to focus in trying to find the exercise or the physical activity that suits the best for that person. And by suits the best, I doesn't mean just by saying the exercise that people is capable of doing, but also mainly the exercise that people enjoy most in doing. So I think the exercise prescription for someone living with a mental health condition should be focused mainly in trying to keep this person active. And that includes find the activity that fits best for that person, in the sense that a person say that, okay, that's the activity that I like doing. That's something that calms me. That's something that relieves me. And that's something that I particularly enjoy doing. Instead of focusing on the best intensity, the best frequency, we should try to focus on the exercise that makes one feels better. And this is like the most challenging thing, and I think that's the most important aspect that we have to have in mind when prescribing exercise for someone with a mental health condition. Try to leave intensity and volume and all the other aspects in a second plan, and try to focus in finding the exercise that people enjoy most doing. Because the best exercise is the one that's actually done. So that's the main thing.
Yes, that makes a lot of sense. Okay, do we have a question for Lu Yang about your associations, and the questions from Nanette again, which asks whether the direction could also be reversed. So boys are more active because they have fewer peer problems. Do you think that's a likely explanation of your findings?
Thanks for this question. In our study, this is a prospective analysis. Physical activity at age 5 and peer problems were measured at 10. And another thing is that we controlled the peer problem conditions at age 5. So in these studies, based on this study design, we would safely to say that the direction cannot be reversed. Another thing is that our study is based on based on Dutch people, Dutch children. When those children at age 5, they haven't go to the school. That means they are random, and the active level we captured actually is the random level of their physical activity. And at age 5, those Dutch children, they not face those peer problems as they face at age 10. at age 10, they already went into the school. So that's another reason we would say safely conclude that this kind of association will not be reversed in these studies. But I agree with you that actually the peer problems sometimes can impact the person's active life, but not in these studies. In like cross-sectional studies and in our reality life, it happens.
Thank you, Lou, for that. We also have a question in the Q&A for Professor Felipe. Pretend you are sharing your results with a curious grandma. In lay terms, what did you find out from your research?
Well, okay. Thank you very much for this question. So we have the partial results so far, and we have just analyzed baseline data. And basically, the main findings to a layperson, explaining to a layperson would be, well, we have observed the same associations we have seen in the literature. So higher levels of physical activity or being more active may be associated with fewer and lesser depressive and anxiety symptoms, and also symptoms others that we assessed. But the main thing is that we can tell so far from the partial analysis is that we have some lifestyle behaviors that are associated with lesser or fewer mental health symptoms, regardless the culture and the country. So we have a diverse set of students from a diverse set of cultures, and these effects are observed in all countries and all cultures. So physical activity and diet, for example, they are cross-culturally associated with better mental health outcomes. So this is something that we can tell so far. And also, we have seen that having healthier lifestyle behaviors in multiple lifestyle behaviors are associated with a lesser risk of having multiple mental health symptoms, including depression and anxiety. So once again, we just have partial data. We haven't analyzed the whole data set and explored it in depth. But for this moment, this is what I can tell. But obviously, we will have much more interesting data coming when we start to dig in the data.
So I had an additional question for Felipe, and now seems a good time to throw it in there. I wondered if you could say a bit more about the confounders that you're considering in your study. So I noticed that I think you mentioned just a couple of confounders, but are there other things that you're thinking about doing in future analyses?
Yeah, well, we have lots of information. We have ethnicity, we have income, we have sex, we have also other treatments, we have previous diagnosis of mental health conditions. So we have we have BMI, we have other confounders. We have a list of them actually. So yes, we do have some to explore. But obviously, it's quite challenging to assess lifestyle behaviors and mental health in a diverse set of students across different cultures and countries. We have some interesting findings. For example, Japanese students, they basically do not report having depression and anxiety, but the prevalence of psychotic symptoms among this specific set of students is quite high. And probably it's a cultural thing. I don't think that nearly 30% of Japanese students have psychotic symptoms. It's just like a way that they understand and read and report some symptoms that can be interpreted as having psychotic symptoms. So this is one of the challenges that we have at this moment. But yeah, we are assessing, going back to the question, we are assessing lots of confounders, potentially confounders.
Great. Yeah, lots of work to do. And that's really interesting, the difference between different cultures.
Yeah.
So I see another question in the chat, and I didn't see if this is targeted for someone in particular, so I'll just open this up to all speakers. But this is from Victoria Whiteford. What are your thoughts on providing additional support, such as behavior change support, when utilizing physical activity to treat mental illnesses in young people? We know that depression, for example, can present with symptoms such as low mood, lack of motivation, fatigue, etc., which can act as barriers to engaging in physical activity. Is there a need for additional support?
I guess just from some of the work that we reviewed, Olivia and others, peer support is clearly important, particularly for young people, and especially for those who have had similar experiences. Those people who recognise and are empathetic with the types of experiences that young people report, particularly in relation to their mental health, but also the barriers that sometimes can have for physical activity engagement. And there is some work that is looking at peer mentoring approaches, but also kind of buddy related approaches, or studies or programs which also include facilitators or providers of activity opportunities who also have similar experiences. And how that can be important in identifying what some of those challenges are. So absolutely, depending on obviously the types of conditions and the types of programs or interventions being considered, that additional support can often be very valuable. But recognizing the authenticity of that experience and the importance of that lived experience is particularly important part of that support.
Probably got time for one more question if there is one, which I believe there is. Is that right, Eleanor?
Yeah, okay, last question then. So this is a question for Lou. Given your take-home message around boys, is there a threshold parents can remember to ensure their sons are not hyperactive in later childhood?
Unfortunately, currently we cannot provide we cannot provide this number for the threshold for the hyperactivity. That's because this study we find the association, but it's still far away from the clinical recommendation. They are different. We check the association by the epidemiology study design, but it's not it's not to explain the causal relationship between the physical activity level and hyperactive. That's why.
All right. Thank you very much, everybody. Back to Gareth.
Lovely. Well, first and foremost, thank you everyone for attending today and engaging in the workshop. It's been a great hour. It's kind of rushed by in my eyes. So thank you. That was really, really interesting. And thank you for engaging. Thank you to Antonio for the platform through ISBNPA. And it's been really good. And hopefully it helps grow the network and so on. I think that's really important. But also a huge thank you to Andy, Felipe and Lou today for your talks. It wouldn't have been so interesting without you guys here today. So just want to really send a big thanks for your contribution and so on. That's very much appreciated. If colleagues wanted to attend but couldn't, this webinar has been recorded and so will be visible in the next few days, I believe. If you'd like to share it, I think it can be found or it will be visible at some point on the ISBNPA website under activities and then webinars. So you should be able to view it in there, as I said, in the next few days. But Antonio can perhaps confirm or deny that.
That's it. And the YouTube channel also, the Society's YouTube channel. Yep.
Thank you. Yeah, forgot about that. But yeah, just thank you very much everyone for attending, and that's it. Thank you very much.
Thank you.